know that the OD dose tacrolimus was launched almost a decade back in our country, but it has been suboptimally used. Probably because the BD dose tacrolimus has a phenomenal outcome with our transplant. So if you ask me, is there still a need for once a day tacrolimus, I would say that once a day tacrolimus potentially improves the inter and intra-subject variability. The compliance is better because it is single dose, and it has a therapeutic equivalence to conventional tacrolimus and same therapeutic monitoring what we do for regular BD tacrolimus. Now, all of us would have seen a situation where our transplant patient who was doing well for a few years suddenly comes with a rising creatinine. We know that invariably it will be a non-adherence, and the level of non-adherence can be as an accidental missing of the dose to a decisive where he decides not to take the medications. And this study looked at what was the causes of kidney transplant failure, and they found that 64% of them almost had rejections. And when they looked into what was the cause of rejection, 47% had non-adherence to the drugs. Say this implicates that non-adherence is not only a problem in our country, probably it's a global phenomena which leads to loss of the graft. Now, other issue with BD dosing is that the night or the evening dose is supposed to be absorbed very delayed and the levels are not optimal. And night dose is the most frequently forgotten dose by the patients. So again, the concept remains a single dose probably will turn out to be a better outcome for the kidney survival. Now, this study came in 2010. They looked at the safety and efficacy. And if you look at the safety and efficacy of Advagraf to Prograf, it was proved that they are comparable. And similarly, when you look at this, it is a single center study. Why I have put it up is it again showed the efficacy being same. But thing is that there was added benefit with lipid metabolism. That is, you are getting some additional benefit out of Advagraf compared to a Prograf, which was a BD dosing. And when they looked at the area under the curve and the levels of the drugs throughout 24 hours, they found that they were comparable. But one most important thing you have to see in this paper is the Cmax was lower for the Advagraf, which may turn out to be responsible for lesser complications that may see with the tacrolimus. So we looked at our experience with de novo OD tacrolimus. So this is a retrospective analysis looking at 24 continuous patients who were on BD tac versus those who were on OD tac. Protocol for immunosuppression was same in both. I start my tac -5 days so that on the day of the transplant I have my day 0 level tac so that I don't turn on lower levels or higher levels which might impact the graft outcome. So MMF was started at 1 gram, again minus day 5, steroid oral 0.5 per kg on the previous night, 1 gram methylpred on the day, 500 milligrams next, 250 milligrams the second day. Then I changed to oral 0.5 on the 4th day per kg, 20 milligrams on 5th day, and regular reduction of 2.5 milligrams every week to reach a baseline of 7.5 by 1.5 to 2 months. TAC level I keep little low, 6 to 8 nanograms per ml post-transplant up to 3 months. And beyond 3 months, I try to maintain it between 3 to 5 nanograms per ml. I would increase MMF to 1.5 grams in a mismatched kidney, that is a spousal transplant or a cadaver transplant. Biopsy is done for all any doubtful, unexplained increase in creatinine. So when you look at the comparison of the general parameters for both the groups, they were comparable in almost all the aspects. And this study, we looked at least 2 years, the patient should have been, we should have data for 2 years. And the total mean duration of this study for both the groups was 42 months and 46 months, which was again comparable. Now, looking at the induction therapy, Advagraf, we were not sure how it behaves, so I tended to give the induction therapy for these patients who had spousal transplant and cadaveric transplant. And in the conventional group, only one patient opted for it. It is not in my protocol. I asked them whether they want it, and I tell them the risks involved, and based on that, if they agree, I give the induction. So what were the observations? You look at the OD tac to conventional tac, the parameters at the last follow-up, they were all comparable, whether it is the dose of the tacrolimus that the individual was taking, or it is the dose per kg body weight and the last dose of the tacrolimus. And average serum creatinine at the last follow-up, they were all comparable. If you look at the tac dose at initial 5.23, in conventional tac, almost matching. So p-values were not significant. So average serum creatinine at discharge and at the last follow-up, again matching. When we look at the scatter of the levels, comparing Advagraf to BD, we found the blue one represents the Advagraf. You see that the scatter is more concise, and it is, more in the therapeutic range compared to the BD tag where it is scattered haywire, saying that the levels are probably well controlled with Advagraf. When we looked at PTDM data, the new onset diabetes 5 patients had, which translates to around 23%. But if in the other group there were 9 patients, translating to approximately 37%. But if you go by the PTDM definition of diabetes after 4 weeks, there was only 1 patient in the OD tag, which was 4.4%, and 5 patients in the BD group, which was around 20%. If you look at the post-transplant infections, mind you, the OD group had induction. 11 patients out of 24 had induction. Still, there is only 1 infection at 2 years, which is 4%, compared to 10 patients in the conventional group, which is around 40%. And the patient and graft survival at the end of 2 years was 100% in both the groups, and there were no episodes of rejection in both the groups. So my take-home message, OD tag is comparable to the conventional BD tag. We have shown it in maintaining the graft function, dose of the drug required, serum levels of the drugs, as well as the patient and graft survival. In this group, I want to point out the fact that usually other papers have said that dose required will be 10% higher. But in my study, we found that the dose required is same. But in our paper, we showed an extra benefit that the infections were less, the PTDM incidence was low, and the study levels of the drugs were maintained. Thank you.